So good morning, everyone. So today it's our honor to invite two professors from University of Illinois Urbana-Champaign. So today's talk will be by Dr. Sheldon Jacobson, and I think it's a really special moment because since 3 years ago we visit the UIUC for the first time in September 2023, I think, yeah. And after that, we have a very frequent, interactions between UIUC and NYCU. So it's really our honor to have you, both of you, to here in Taiwan. And today we invite Dr. Jacobson to give us a talk. And Dr. Jacobson is a founder professor of computer science in UIUC, and he is also director of the Simulation and Optimization Laboratory, and also the founding director of the Bedtime Research Institute at the UIUC. So he also holds several appointments in different colleges, including the Industrial and Enterprise System Engineering, Electrical and Computer Engineering, Mathematics, Statistics, and also College of Medicine. And also Dr. Jacobson received a Bachelor's and Master of Science in Mathematics from McGill University, and also holds a PhD in Operations Research from Cornell University. So today, I think it's really because we have so we have, in our College of Medicine, also in our teaching hospital, we already have lots of the AI projects is ongoing. But what I observe is that although we have lots of AI models at this time, but actually very few already been implemented into the clinical practice. And one of the problems is that even we develop AI model, the doctors doesn't know how to implement into the clinical practice. So it's really a good moment that maybe Dr. Jackson can share your wisdom that what's the lesson to developing the AI model in the healthcare. So let's welcome Dr. Jackson. Yeah.
Good morning, everybody. If you're a medical student, could you raise your hand so I know who all the medical students are? Excellent. Well, we are going to ask some questions along the way, so you're going to have to answer them as well, so I don't want you to fall asleep or anything like that. How many of you think that at some point in your medical training, you're going to be interacting with artificial intelligence? Most of you should be raising your hand because artificial intelligence is going to become a very important part of what you do. It's going to affect and impact the practice of medicine for the rest of your career. How many of you think that artificial intelligence may replace you as a physician? That's a much more difficult question to answer. Well, I'm going to talk to you about a few things. Really, this talk is broken up into two parts. One is going to be a research project that I worked on with a graduate student as well as Dr. Jokala. And the other one is going to be some of the lessons I've learned in not necessarily being a user of artificial intelligence, but a creator of artificial intelligence. So as a computer science professor and engineer, I don't have a medical degree. But I have interacted over my career with many people in the medical community, including my wife. So it doesn't want to go. I guess we'll do it that way.
Maybe 1 second.
There we go. All right, you have the magic touch. So just some disclosures. I have been funded by the United States National Science Foundation throughout my career, and these are a couple of grants that I've had that have been particularly relevant to some of the things that we're going to be talking about today. And I also have a personal disclosure, which is my wife, Dr. Janet Jokla, who's going to be talking to us tomorrow. And she's an internal medicine and infectious disease doctor. She's also the senior executive dean for engagement at the Carle, Illinois College of Medicine. And we've collaborated on several papers, actually, through my career. And she's even helped with many of my PhD students. So as a result, it does give me an inside scoop when it comes to being an engineer and looking at medicine. So just to give you some background of what I've worked on over the last, over 3 decades now, I've looked at many different problems which have existed in medicine, and the vast majority of them have used some aspect of artificial intelligence to gain insights. One of them has been clinic design and patient flow. This is one of the earliest problems that I worked on, and how you actually optimize the flow of patients and the design of a clinic so that you get the most effective practice of medicine. We also looked, and this was work that we did with the United States Centers for Disease Control and Prevention, looking at pediatric vaccine formulary design as well as pricing issues and stockpiling. And we did this actually for several years. They had approached us quite a while ago, and we looked at different issues associated with pediatric vaccines and immunization. We also looked at a problem related to obesity, transportation, and fuel consumption. And this was a problem we looked at as a public health way to tackle obesity from a non-medical point of view. One of the things we discovered is that communities that have a strong public transportation infrastructure also tend to have lower obesity rates in the United States. That's not surprising, and if you look around the world, if you look in Taipei, we have a very strong public transportation system, and in our time here so far, we don't see a lot of people who are very heavy, and I think there is a strong association with that. So we wrote a few papers, and a master's student actually did his dissertation around this. We also looked, and this is an issue, I don't know if it's true here in Taiwan, but it's certainly true in the United States, is that automobile accidents, over 40,000 people every year in the United States die in an automobile accident. And as a result of that, part of it is distraction. So we looked at data. Once again, everything is driven by data, to see if there was some kind of indicator that we can tease out, saying our cell phone bans, people using their cell phone while they're driving, is that actually going to create safer roads? And we wrote a few papers on that and published them around that one. So once again, not clinical medicine, but much more public health associated. In the United States, another issue, of course, is violence and guns. And this is another issue that, of course, we have to deal with. And we looked at trends in mass murders and trying to look if there's ways to actually model that this occurs. And then another fun project, which Dr. Jokla was involved in, is a residence scheduling. That when you have large resident programs who have to do many different clinics and shifts, how do you actually schedule them? And we wrote some models, some AI models, to help us do that. And a more recent problem involved COVID. We all know that people were affected by COVID, but at the same time, this is falling down. At the same time, we also understand that there are people who die from COVID. There were people who died with COVID. So as a result of that, what we wanted to do is look at excess deaths in a manner that, no, it's fine. We'll just put it here. And look at it in a manner, and I'm going to talk about that in much more detail. So we published a paper about this. We published actually several papers, but I just chose one of them, which was in Healthcare Management Science in 2022. And it had to do with the excess deaths, the premature deaths. This was joint work with a PhD student of mine, Ian Luden, who now is a faculty member at Rose-Hulman University in the United States, and Dr. Jokla and myself. So what do we mean by excess and premature deaths? Because we all know that when people got sick, certain people died. They often tended to be older. They tended to have underlying health issues. So as a result of that, if you looked at the media reports of this, it often did not always give a very clear picture. So what we wanted to do is uncover what was really happening. And fortunately, there was data available. I don't know if it's still available, but it certainly was available at the time, that we could uncover what was really happening in terms of the effect. This is all, of course, based in the United States. Now, anytime you're going to do data-driven research, you have to have data-driven research questions. And the foundation of everything that we do when it comes to experimental work is always the scientific method. So for those of you who are working in labs, ultimately you're going to have to ask a question. And if you don't ask a question, you won't be able to get an answer. So we asked a number of questions. And once again, we wanted to avoid the media hype and focus our attention purely on what the data was saying, because the data would tell a story, but we had to create the models to help it tell that story. So we asked, for example, how do, over these 3 periods of time, 2023, 22, and 21, how did the mortality rates compare to what happened in the first year of the pandemic, and also pre-pandemic? So we looked at a baseline from 2015 to 2019. We also wanted to know, can this increased mortality, can it be explained solely by the deaths which are attributed entirely to COVID-19? And this, of course, was a big debate in the United States. Were people dying from COVID or were they dying with COVID? And we wanted to see if we can tease out some of these insights. And ultimately, did mortality rates return to the pre-pandemic level, so that by the time we got to 2023, when things were in fact slowing down, were we in fact seeing a return to normalcy, whatever normalcy would represent? So the CDC, the Centers for Disease Control and Prevention in the United States, is a wonderful organization. They've always been a tremendous repository of data. That has changed more recently, but certainly at that time it was there. And they provided a tremendous amount of mortality reports, frequently giving the total deaths per weeks. And they also distinguished the deaths from COVID, but also the deaths with COVID. So if someone had an underlying condition, possibly cancer, heart disease, obesity, and they died, one wanted to tease out what was the true cause. Was it the underlying health condition, which COVID in fact took advantage of it, or was it COVID itself? They were a healthy person who just died. We also broke things up into different subgroups. One was gender, whether they were male or female, but also many age groups. Infants under 1 year old all the way up to people who were over 85 years old. So we had a wide spectrum of characteristics that we wanted to look at. Once again, not just listening to what we saw in the media and heard in the media, but looking at what the data was saying. And the source of all this is a wonderful website which is called Wonder. I did check this morning. It is still there, and that is, of course, a good thing. So here's a chart which shows you, and this is kind of a big picture summary, where if we look going back to 2015 all the way up to 2022, we see the number in thousands of deaths, so a little over, around 2.7 million people died in the United States in 2015. Of course, as the population grows, there are going to be marginally more deaths. So we did a simple linear regression model, and you can see where we would end up all the way through 2022, and of course beyond. But in red, we see what the COVID deaths were. And we see that there was this perturbation of deaths that, in fact, was attributed to what was happening during the pandemic. So we knew at the very highest aggregate level that something was happening. That was well documented, of course. We can also look at another picture which goes from the beginning of the pandemic all the way to April of 2023, and we see that there is a kind of a wave of deaths that occur. But then, as you see in blue, those are the predicted number of deaths from all causes, including COVID. So it's not just the people who died with COVID or from COVID, it was everything, absolutely anything. And the interesting thing that we observed from this is that there were people who were dying had nothing to do with COVID, but they were dying at a higher rate for things that were inexplicable. And that's when data becomes very valuable. You know it's telling you something. It's telling a story. The question is, what is this story? And can we in fact translate it and understand it? And this is an example why just looking at the picture, it is very informative. But at the same time, we'd like to be a little more quantitative to be able to fully appreciate what is happening. So what we did is we said, well, let's look at some very traditional medical statistical measures to help us do this assessment. One is death risk, and that's basically capturing the odds of someone dying. It's simply the ratio, I call it here delta over beta, but it's basically going to be the ratio of the number of deaths over a particular time period by the number of people who didn't die, which is the population minus the deaths. We can also look at the odds ratio between two different time periods, where we would take basically the ratio of the death risk, the delta over beta. And then from that, we're going to construct a confidence interval, so we're going to need an estimator of the variance or the standard deviation. And when we're using 99.8 confidence intervals, which some of you may think, how many of you have seen confidence intervals in your work at some point? You probably all have. And you often think of a 95% confidence interval as being the standard to use. And you'd think, well, why don't you use a 95% confidence interval? It'd be much tighter, of course. The reason is that we have so many different subgroups. If we used a 95%, there was a high probability that we would actually have a false positive. So as a result of that, we wanted to make the confidence interval so tight that with so many confidence intervals, we would be confident across all of them. For those of you who may have seen this in a statistics class, this is called the Bonferroni effect. And that's basically what we wanted to account for. So just to give you an example, if we look in 2021 versus 2015 to 2019, our so-called baseline period, and we looked at the death risk for 35 to 44-year-old females, we did the computation of the death risk for the two time periods for this particular group, and we created the odds ratio and then a confidence interval for the odds ratio. We see exactly how we would compute this. The data is all available, which is nice, of course, and we were able to compute this in a very straightforward way. But what we really wanted to do is tease out some insights. What can the data say? And this is an example where the data is available, but it's not just having the data that's important, it's how we use the data that's important. And for those of you who are going to do any kind of research involving data and AI, this is going to be a critical part of your process. Because simply saying, oh, we've got all this data, let's use it, but how are we going to use it? And this is when we had to think a little bit more of what we can do. So on the far side, we did, as you see here, from the 11 groups, and then both males and females, so the 22 different groups, we looked at these 99.8% confidence intervals, and what we wanted to compare was the 2021 period to the baseline pre-pandemic period. And one of the things that we see here is that, and this is not surprising, that certainly when people were older, when this ratio is above 1, it means that the death risk in 2021 was higher than the baseline pre-pandemic. And of course, we all know that older people were hit heavily. But and even though less people in absolute terms were being affected from, the age group from 25 to 34 and 35 to 44, their death risk odds ratio is actually even higher than the older people. The absolute number of deaths was not as high, but the risk to them was higher because they're not dying at such a high rate, but COVID pushed them over the edge. And this is true for all deaths, for total deaths. So it includes COVID as well as any kind of death. If they had a heart attack and had nothing to do with COVID, it's still included in that. The other interesting thing, of course, are the people who are the very youngest, and we see there that they're only marginally affected. And in some cases, even for those who are infants, they were not affected at all very much. And part of that explanation is that the major risk factor, at least in the United States, for infants is accidents. And as a result of that, with people staying home, there were less opportunities for accidents, and it became protective to them rather than a risk factor. But if we look at the non-COVID deaths, this is where it gets very interesting, because these are people who it's not attributed to COVID. They just died. And we see that for the oldest group, the death risk was actually greater in the pre-pandemic period than during 2021. And the reason for this is what we call mortality displacement. You can't die twice. I know, once you die. Which means that there are people who died in 2020 who probably would have died in 2021, but because they died early and prematurely, it meant that they were dying at a lower rate in 2021. They had already died in 2020. But once again, if you look at that middle group, that 25 to 34 to 34, 35 to 44, and 45 to 54 group, that group is being hit really hard, not just by COVID, but by the fact that they're not having screenings. There's just so many societal factors that went into this that they were being, in fact, affected greatly. And these are things that were not discussed widely initially during the pandemic in the United States, but later on started to be. So let's now look at 2022 versus the baseline. And once again, the death risk of all deaths total, once again, is still above 1, which means that there is still some risk. But the interesting thing is that younger people are actually at more risk than older people during that time period. And once again, it had a tremendous effect on this community. They don't necessarily die at large numbers, but their risk was increased. If you look at the non-COVID deaths, you have a very similar effect in terms of mortality displacement, that people have already died, they can't die again. But the younger people are once again affected greatly. And whether this is mental health issues, whether it's accidents, it could be anything. All we know is that they were being tremendously affected, independent of the pandemic's effect on their body. Because we all said, oh, if you're young and you're healthy, it doesn't really matter. But the change in society impacted their mortality risk. That's what we were seeing from this. What about the second year versus the first year? Was the second year riskier or not as risky as the first year? So we did that comparison as well. And once again, on the far side, we see for the total number of deaths, the older people, they died early, which means it's the second year, they weren't dying again, which means there was a lower death risk for them. Everybody else, certainly the people under 54, they were basically still at risk overall. It was a societal shift, which I think many of us underestimated at the time, but the data is screaming this out, that something's happening. If we focus purely on those dying from non-COVID related deaths at all, we see that the biggest group that's being affected are the very youngest, in particular 1 to 4 years of age. Many of them, for example, may not have gotten their vaccines, their immunization. And as a result, they were vulnerable to infectious diseases, which is a very high risk for this group. And you start to see the story unfolding from the pre-pandemic period to the pandemic period to the post-pandemic period. And you start to see the evolution of the disease and how it affects us. Here now we're going from the third year to the second year. And this is where it really becomes very, very pronounced. Because once again, if you look at total deaths, a lot of people died. In fact, if you look at the group from 15 and above, so many of them died is they just died prematurely. This was a premature killer. That's all it was. But the young people continued to suffer, which of course was somewhat surprising. If we look at the non-COVID deaths, once again, we see that the older people, they can't die again, but COVID was still affecting people. If you look at the first chart, even for that older group. So we often say it's become benign, and it's become, I think the better way to say it is more benign. It's not as lethal, but it doesn't mean it's not lethal. It just means it's not as lethal. There's no good reason to get infected. That's the bottom line. But that young group, if you look at their non-COVID deaths, they are still continuing to suffer. So this is kind of a takeaway where people argue that we don't have to protect the young people because it's not going to affect them. The fact is the data says it has affected them, and it continues to affect them, which is a true risk factor. And if we cannot protect the young in our community, then who are we going to protect? They are the future of every country, and we have to be very, very thoughtful about that. So the key findings is that yes, COVID certainly affected all of the classical people that we believe, the older people. But in many ways, it was not just killing people, it was prematurely killing people. It was taking life away from people who would have died maybe a year, 2, 5, or even 10 years later. And those people can't come back. The risk profile changed with time. It continued to change with time, and so many things went into that. It just shows you how complex it is to be a physician. For those of you who are students, medical students, you're going to be treating people, and you're going to be presented with cases and situations, and ultimately you want to bring compassionate care and life and quality and quantity of life to people. You're going to have to take into account a lot of things, and this is where AI can be such a valuable asset, because it can tease out insights that maybe you cannot just detect. Dr. Joko will talk tomorrow about so many things about compassionate care, and I think it's really important for us to keep in mind that, yes, we want to see as many patients as possible, but we also want to see patients in a productive and a quality way. And the data indicates that that is a priority for what we do. So, what are the lessons learned here? Now I'm going to give you some very general, but I think important lessons that I've learned over the last 30 years in working in healthcare with AI. There's a lot of data around, and data-driven decision-making is really very important. But not all data is created equal. There are certain quality and quantity limitations. Data is a great way to look in a rear-view mirror. But if you're only looking in the rear-view mirror, and you're driving your car, you may end up hitting something in front of you. So you have to be very, very cautious when you use data, and know what you're using with the data. What data to use and how to use it is the key. Often, as a physician, you're not going to be the creator of the data, nor the creator of the AI. I do that. You're going to be the consumer of that. But by interacting with people in computer science, like myself, it's important for you to at least have some education of what you're getting into. Because if you go into it and thinking, they'll take care of it, you may find yourself being misled. It is far more complex. I think of AI as the Wild West of analytics right now. And it's a dangerous place if you don't know what you're getting into. The other thing is that how many of you have used ChatGPT at some point? Anybody? And it's great. It's fun. It's interesting. And you don't know what it's giving you sometimes, because it's being trained on data that is just in and on the web. And some of it isn't right. And it doesn't know that. It's not smart enough. These large language models are massively overfitted statistical models, typically neural networks and deep learning neural networks. And it's not smart. It looks smart. It looks really, really smart, but it's not. All it is a model. And it gives you some useful information, but you have to be cautious. You have to use your head to make sure that what it's giving you is going to be informative. So the methodological AI tools that exist are far more than the large language models that are embedded in generative AI. Computer simulation is a very powerful tool. I actually teach that course at the University of Illinois. Mathematical programming, which are typically optimization type models. Some of them are embedded in how you design your large language models. Stochastic models like Poisson processes and Markov decision processes are certainly also decision-making tools. And statistics is the broad field which includes machine learning and neural networks and all of these things. So these are the underlying methodologies that go into the very things that you have used and are going to continue to use. So the role of AI modeling, though, is really about making decisions and making them better. I remember when we started working with the Centers for Disease Control, they were making decisions about vaccines and how to stock these formularies, these set of vaccines, and there was a really smart guy there. And our goal was to create a model that would do as well as him. If we can achieve that, we were successful, because he was so good. His brain was better than anything we could have created. But if we could have gotten within 90% of how well he did his analysis, that was a phenomenal feat. And it took us many years to be able to achieve that. So decision making is an important part of the process. But at the end of the day, the AI model will give you input and insight, but the human being ultimately has to make the decision. Resource allocation. As a physician, you're always going to be constrained by a limited amount of resources. I'm sure Dr. Albert understands that as the dean. And the fact of the matter is, we want to use our resources wisely and optimally. And we often think, well, we'll get the most out of the situation. But we also want to do them to serve the needs and interests of patients. That's always an important thing. Efficiency. And there's this trade-off between time and cost. We do it with less time, it costs less money, we can do more. We have to be careful, because there's a reason why there's a bit of inefficiency built into medicine. And it's because of the unpredictability of so many of the processes that we're dealing with. And ultimately, you want to solve a problem. And you want to somehow, some way, allow AI to help you solve these problems. But you, ultimately, as the physician, are going to be the problem solver. AI isn't necessarily going to solve it for you, but it's going to give you help to make a better problem being solved. So what are some of the lessons? Now I'm going to give you some very practical things to think about. And this comes from my experience of working with people in medicine and not being on the clinical side, but being on the AI modeling side. One is knowing the stakeholders. That when I've had to work with people, I had an idea of what I wanted to do. And then I talk to the clinicians, I talk to the public health people, and they tell me something different. I had to be educated about that. And your role as a future clinician is to help people like me understand. And if the person like me doesn't want to understand, don't work with them. They are not the right people to work with. Just because they have sexy software and data sets doesn't mean they're the right people to work with. You want to make sure that these people are willing to get their hands dirty and learn about the domain, because at the end of the day, the person who's most affected by this is the patient. And if there is not this segue, this pathway from the AI to the physician, to the patient, it's going to be a rough ride. So that's the first lesson. The second lesson is learning the language and learning the culture. In computer science, we have something called a Turing test. And the Turing test is you have behind a wall something that is interacting with you. And it could be a human being, it could be a computer. And you ask it questions. And you try and find out, after all these questions, are they a human being or are they a machine? And if you believe it's a human being but it's a machine, then that machine has passed the Turing test. Same thing with healthcare. You want to make sure that when you're doing the modeling, that you're understanding the language and the culture of what's in medicine. There's a lot of off-the-shelf products in AI that are saying, wow, this is great, look what it does. And I'm sure some salesperson will come along and sell it to you and offer it to you to make your practice better. The reality of the situation is every practice is still a little different and will have to be fine-tuned. So collaboration, integration, and dissemination are critical factors. And it's a way, in fact, to assess or judge whether the AI tool that's being presented for your use, whether it's in research or clinical time, is in fact the right one. Lesson number 3. If models are hammers, not all healthcare problems are nails. In essence, what it is that we often try and think, oh, I've got this powerful tool, so I'll make it work here. But the fact of the matter is, it doesn't work that way. Listening, especially from my point of view, is so critical, and building these relationships and these bridges between people. And you, as a clinician, a future clinician, you want to be part of that process. You don't have to build the models, but the people who you're working with, who are building or offering the models, they have to make sure that the problem that they're solving is the right one. Which really takes us to lesson number 4, models chasing problems versus problems chasing models. Many people in my field, we're modelers, and we like to build AI-type models, and they're fun and they're elegant, and then we say we have this great abstract structure. Now we need to find an application for it, and we look around to seek that application, and this is very common. And the trouble is, this doesn't work very well, because if the ultimate motivation is not the problem, then what you're trying to do is you're trying to potentially fit a square peg into a round hole. And that doesn't do anyone any good. So the ideal situation is that you have the problem. You have the situation. You need the decisions made. You need the support. What can be built for your purposes? And sometimes off-the-shelf AI systems will work, but sometimes they have to be fine-tuned and sometimes they just don't work. Don't assume that if something sounds too good to be true with AI, it probably is. It probably is. And it takes time to be able to make sure that we're solving, in fact, the right problem with the right tool. Data. Data is the oil that makes models hum. And as accessing data, it's critical that when you're presented with an AI system to ask the question, how was this AI system trained? Where was the data taken from? Because all data has bias. We all have, human beings have bias. And depending on where we get that data, that bias will be present. And if that bias is not acceptable to you, then you're going to end up in a situation that the data is not going to help the model and help your decision-making process. So with data, you have quantity, and you always need a lot of it. Quality is always a critical issue. And then the granularity, something you don't necessarily think about it, because you can have data where you're looking at it from 1,000 meters above the ground, or you're looking at it with a microscope and everything in between. The granularity of the data is so critical, because if there's a mismatch in the granularity in the same model, you end up with bad models. I've seen that happen many, many times. Lesson 6, good solutions to the right problem, that's much better than optimal solutions to the wrong problem. Once again, if it sounds too good to be true, it probably is. That sometimes we have to sacrifice a little bit and come up with a reasonable solution, but it's solving the right problem, as opposed to something that guarantees wonderful, insights, but it's not the problem that you're presented with. It's just not confronted. And always understanding that trade-off. The people who do AI, they want to solve the problem that they like. But if it's not your problem, then it's not going to give you the help and the insights, and you'll end up spending time, money, and resources, and will give you no value and benefit. Number 7, think. Think and more think. Thinking is critical. AI is not going to change that, and it's not going to replace your brain, at least not yet. It's important for you to realize that you have to have a critical eye, a curiosity, and you have to vet everything that is put in front of you. Like I said, if something seems too good to be true, it probably is. And AI is wonderful. I love it. I've made my career around these kind of models, but at the same time, I understand its limitations. And it's not something that people will always tell you of these limitations, especially when they're trying to sell you a functionality. It's important for you to have a critical eye and ask these kinds of questions and think about what they're offering and whether it really is of benefit to you. I want to thank you all for being here and listening, and I certainly will answer any questions that people have.
Yeah, thank you so much for a wonderful talk.